My name is Susana Lobo. I am the head of Intensive Care Division em Hospital de Base São José do Rio Preto, São Paulo, Brasil. It's my pleasure to talk about source control in low resource settings. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world, and the greatest burden is in low and middle income countries. Along with early administration of fast and appropriate antimicrobial therapy and supportive resuscitation measures, source control is a key element of success in therapy of sepsis. It includes all physical measures undertaken to eliminate a source of infection and control ongoing contamination. That comprises drainage of abscess, debriding infected necrotic tissues, removal of a potentially infected device, or definitive control of a source of ongoing contamination. And also restore premorbid anatomy and function. Diagnosis is the main piece of the puzzle. History and physical examination is the most valuable method for source detection and should be undertaken in timely manner. Sometimes symptoms are explicit, suggesting a specific site of infection. Diagnosis is not difficult. Many times symptoms are vague. In this study, more than 1/3 of the patients with septic shock were admitted in the emergency room with vague symptoms. And we should pay attention to patients with vague symptoms. They are at higher risk of receiving delayed antibiotic administration and higher risk of mortality. And physical examination should be undertaken in timely manner from head to toe. Not only abdominal infections need source control. All possible sources must be verified in every patient presenting with sepsis. Albeit, many patients with sepsis will not need source control. They need a correct diagnosis of the source of infection. And daily, we face different sources. Classically, drainage has been accomplished by planned surgical intervention to evacuate an abscess cavity and leave a drain in situ. More recently, interventional radiologists have come to play a primary role in establishing source control, especially in deeper site infections. In the picture in the left, we can see a pelvic abscess in an elderly patient after diverticulitis. Catheter inserted after drainage, we can see in the right. Debridement is the removal of dead, devitalized, or infected tissues. A classic example is the case of necrotizing fasciitis. Surgical debridement is essential for surviving such cases. Ideally, it must be done in 1 or 2 hours if spreading rapidly. Similarly, after intestinal infarction, excision of the death bowel is potentially life-saving. A colonized foreign body serves as a continuing source of infection. Many of the organisms that predominate in infections in the critically ill have the capacity to form a biofilm on invasive devices and so create a continuing focus of infection. Foci of infection readily amenable to source control include many possibilities, including amputation for Clostridium necrosis of the muscle, specific anatomic diagnosis of infection requiring consideration for emergent source control must be done as soon as feasible, with the exception of peripancreatic necrosis, in which definitive intervention is best delayed until adequate demarcation of viable and non-viable tissues has occurred. But selection of optimal source control methods must weigh the benefits and risks of the specific intervention. Planned surgery, percutaneous drainage, laparoscopy, it depends on clinicians' expertise and availability of resources. Probability of the procedure's success must be taken in consideration. In general, the least invasive option that will be effective in the control should be the choice. Regarding time to source control, we have now evidence that lack or delay of source control has been associated with worse outcomes. Let's look at the results of some studies. In this observational Spanish multicenter study in 99 ICUs with various sources of infection, abdominal, urinary, and soft tissue infections, the authors evaluated more than 3,600 patients, 32% of them requiring source control. Despite greater severity and worse compliance with resuscitation bundles, mortality was lower in septic patients who underwent source control than in those who did not. For those requiring source control was achieved in less than 12 hours in 70% of the cases, and the time to source control could not be linked to survival in this specific population. Same results here in this small single-center Brazilian study. They did not find differences in mortality in patients with sepsis or septic shock undergoing abdominal septic focus clearance less than 12 hours after the diagnosis or more than 12 hours. In this large registry-based study in 11 emergency departments with more than 2,200 patients in Korea, with 60% undergoing percutaneous drainage, around 20% emergency surgeries, 15% endoscopic interventions, and 6% removal of infected devices, they found 28 days mortality significantly lower in patients in whom source control was achieved, almost 50% decrease in mortality. They too did not find association between the time to source control and 28-day mortality. But with more granular data, we can see differences. These authors evaluate the time to source control in relation to the start of hypotension. We can see that the rapidity of the source was implemented after the advent of hypotension was a major determinant of septic shock survival. If less than 3 hours, mortality was 25% in comparison to 64% if we see a 12 to 18 hours interval. Another very important MEDUSA study, a prospective observational multicenter cohort study 44 German ICU with more than 1,000 patients with sepsis. Among 422 patients receiving surgical or interventional source control, those who received source control later than 6 hours after onset of organ dysfunction had a significantly higher 28 days mortality than patients with earlier source control. And in the multivariable analysis, time to source control longer than 6 hours was an independent predictor of mortality. And we have studies with more homogeneous populations, In this sample, only patients with gastrointestinal perforations, more than 2,600 patients, and 26.5 overall mortality within 30 days. In this graph, we can see cumulative percentage of patients treated surgically and percentage of patients alive 30 days after surgery in relation to time after hospital admission. In this study, every hour of surgical delay was associated with a 2.4% decreased probability of surviving 30 days. It's important to note that a substantial number of patients had delayed surgery. And this Japanese prospective observational study in patients of gastrointestinal perforation with septic shock. What is interesting about this study, besides the more homogeneous population, is first that they implemented a protocol to initiate surgical source control immediately after admission, early source control. And it was performed along with early go-direct therapy protocol during early resuscitation. The authors evaluated time to initiation of surgery and 6-day outcomes associated with each 2 hours delay in surgery. Logistic regression analysis demonstrated that time to initiation of surgery was significantly associated with death, a 70% decrease in the odds of death. The survival rate fell as surgery initiation was delayed and was 0% for times greater than 6 hours. About the necrotizing soft tissue infections, average mortality rates reported remained constant around 20% over the past 20 years. And we have this meta-analysis showing surgical treatment within 6 hours, resulting in 19% mortality rate compared to 32% when surgical treatment was delayed over 6 hours. Among 4,962 patients with community-acquired sepsis in multivariable models, early source control reduced the risk-adjusted odds of 90-day mortality by 29% compared with late source control. In this table, we see the association between early source control and 90-day mortality across subgroups. Early source control was associated with greatest risk reduction among middle-aged patients within 35 to 54 years, male sex, and among gastrointestinal and abdominal and soft tissue interventions. Then, clinical experience and the late studies do suggest that without adequate source control, many severe presentations will not stabilize or improve despite rapid resuscitation and appropriate antibiotic therapy. Therefore, it seems that prolonged efforts at medical stabilization instead of rapid source control for severely ill patients are generally not advised, especially for septic shock patients. Then, 2021 Surviving Sepsis Campaign guidelines recommend identifying the anatomical source of infection that may require source control and implementing this as soon as logistically and medically possible, ideally in the initial hours after development of sepsis. If intravascular access devices are a possible source of sepsis, they should be removed promptly after other vascular access has been established. In general, If source control is readily achieved, short courses of antibiotics are acceptable since the focus of bacterial dissemination has been eliminated. Prolonging antibiotic treatment should never be an alternative to source control. Ongoing organ dysfunction, despite appropriate therapy, should prompt a search for a correctable cause. A CT scan, if available, is the best tool for investigation. Extending antibiotic therapy beyond 5 to 7 days is a reasonable option when, despite optimal efforts, source control remains inadequate or uncertain. If there is ongoing organ dysfunction, failed source control is possible. Some reasons for additional interventions could be bleeding, infection, fistula, or organ injury. Source control interventions themselves can cause further complications. Need for additional interventions or persistent inflammation significantly impacted the ICU length of stay, and patients had worse outcomes. Most of the studies presented here were performed in high-resource settings. The 2021 guidelines largely apply to high-resource settings, but discuss applicability of the recommendations to lower resourcing settings. We have to acknowledge that the spectrum of surgical sepsis may be different in different parts of the world. In South Africa, it is different to that seen in the developed world. Intra-abdominal sepsis is the most common surgical sepsis and is overwhelmingly caused by acute appendicitis. Diabetic foot infection is a major cause of sepsis, reflecting the increasing burden of chronic disease in South Africa. Also, procedures to obtain source control may vary largely among countries. In low and middle income countries, complicated intra-abdominal infections and soft tissue infections comprise a large proportion of surgical sepsis. Emergency cases predominate, and patients often present in delayed fashion. Source control in soft tissue infections ranges from debridement to amputation. And the cases are frequently complicated by malnutrition, advanced diseases, and various comorbidities or coexisting disease process. It is estimated that provision of basic emergency and essential surgical services could avert 1.5 million deaths each year. Of course, specific etiologies and epidemiology as causes of surgical infections linked to different regions of the planet has to be taken into account. Surgical site infections rates in low and middle income countries range from 80 to 30% of the procedures, making them the most frequent healthcare-acquired infection with substantial morbidity, mortality, and economic impacts. There is a huge difference in the annual GDP spent in health among countries. Burden of sepsis highlights public health and acute healthcare delivery system challenges. Poverty, health inequity, under-resourced, and low-resilience public health, as well as inadequate acute healthcare delivery systems, are fundamental contributors to the burden of sepsis in low-resource settings. And there are many barriers in low-resource settings. Poverty-associated conditions such as poor preventive health care, limited vaccine coverage, malnutrition, substandard living conditions, and exposure to environmental and animal vectors increase risk for acute infections. These factors are further exacerbated by delays in identifying and reaching appropriate care. Referral patterns also contribute to the risk of delayed surgeries and antimicrobial drug resistance. Inadequate systems to prevent healthcare-associated infections, and lack of capacity to provide post-discharge follow-up and care. Some of the key steps for improvements in low-resource settings are listed here. Sufficient healthcare facilities, emergency room, surgical and critical care, material and human resources, supplies and diagnostic capabilities. We need to improve referral patterns, data-driven guidelines, inclusive research. Telecommunication will help more distant facilities, and of course measures to reduce the burden of sepsis. And thank you so much for your attention.